now move to our second panel regarding community engagement. We've now heard from experts on the progress and the challenges around the behavioral health workforce. So now we want to talk about current programs and pilot programs that are in progress around the state, the various ways that they can contribute to addressing the mental health crisis. These next panelists have a strong commitment to healthcare justice and can speak more about how collaborating and peer-to-peer support can be transformational in serving communities. So we have three speakers: Brett Feldman, director and co-founder of USC Street Medicine; Dave Jalot, the co-chair of the Firefighter Behavioral Health Task Force, CPF, California Professional Firefighters 7th District Vice President, and President of the of LA County Firefighters Local 1014. I'm sorry if I mispronounced your name. Got it, good. I'm sensitive since my name gets mispronounced all the time. And finally, Dr. Vival Banvadia. Did I pronounce that correctly? Banvadia?
Yeah, that's perfect.
Okay, great. Got it. Second time. A physician with Advantage Healthcare Services. So why don't we go in that order that I listed you? We'll start with Brett Feldman.
Great. Hi, my name is Brett Feldman, and thank you, Senator Wiener and the committee for allowing me to come and talk to you today about what's going well in the world of behavioral health care and care for our neighbors experiencing unsheltered homelessness. And what's going well is street medicine, which is defined as the direct delivery of health care to people who are unsheltered, which is 75% of our homeless population, in their lived environment. I've been practicing street medicine since 2007 and now serve as the director for street medicine at USC. We provide about 10,000 office visits a year, except our offices are under the bridges. We also host the California Street Medicine Collaborative, which is our statewide organization. We have about 130 organizational members and have a pretty extensive workforce development and education arm, which trains and equips others across the state and really across the country to do this work. But the reason why I'm here today and the reason why street medicine needs to exist is because people experiencing unsheltered homelessness can't access healthcare the way the rest of us do. And so you start with extreme poverty plus social isolation. Then you add severe and untreated physical disability, substance use disorders, and mental illness. And then you top it off with a healthcare system that was never designed to serve them in the first place. In California, we've done a great job of making sure folks are insured. Between 60 and 80% of the people were insured, but only 7% are actually able to access their PCP, and only 3% are actually able to be seen by behavioral health care. And so in response and recognition of their sacred humanity, we go to the people, first to deliver an understanding love, and then the same quality of care on the street that you'd expect in a brick and mortar clinic. Our teams are made up of doctors, PAs, nurse practitioners, nurses, social workers, and many others, but the backbone of the teams are our community health workers, the people with lived expertise in homelessness who act as our street guides and make sure that we don't lose anybody. But we also know that healthcare is more than an office visit, even if that office is literally on the street. So we dispense medications, draw labs, do ultrasound, EKGs, all in the patient's lived environment. And this approach is distinctly different from mobile medicine or RV medicine, where you park the RV, people leave their encampment, even if they're worried about everything being stolen, to go to the RV. Instead, we go to the people with pickup trucks and backpacks and deliver care in their environment where they feel most comfortable. And at USC, we've had very good results doing it this way. For example, we've shown we can decrease hospitalization by 70%. But as it relates directly to behavioral health, because that's the charge of this committee, there are three continuums where we serve as that keystone, that stabilizing piece within the continuum. The first one is just access to behavioral health care, which you already heard a lot about. And so last year we published the California Street Medicine Landscape Analysis, which showed 70 to 80% of our programs are diagnosing and treating mental health conditions. We've had to train ourselves up to practice at the very top of our scope of practice as primary care. And the reason is because in that same report, if you add up the total number of street psychiatrists in the state, you get 5 FTEs. But we've actually had good results in doing it this way. For example, we prefer to use long-acting injectable antipsychotics. I give 1 injection. It lasts for a month. It's never lost or stolen or traded or degraded by the elements. It's just in there. And so using that treatment, for example, I remember giving Bullet his first injection behind Carl's Jr. for his schizophrenia. And in a few months, I look forward to watching him graduate as a drug and alcohol counselor to go back to the community to serve. I remember giving Jose his first injection also for schizophrenia outside of his broken down Corolla, where he lived with his family and 2 little girls. And after treatment, he was able to organize himself enough to complete housing paperwork, register his girls for school. And one of the happiest days was seeing little Amelia, who at the age of 9 went to school for the first time. I remember her leaving her Corolla, going to school, and she was so proud of herself, but I think even more proud of her daddy. The second area where we serve as that cornerstone is in housing. Since 2018, at USC, we've housed between 30 and 40% of everybody we see. And the reason is because medicine is seen as an instrument of peace, where we can build these trusting relationships quickly, start treatment immediately, and then refer into housing. And while they're waiting 5 months, 6 months, a year for housing, we continue to follow them so that when housing does come through, number 1, we know where they are, we haven't lost them. And number 2, their physical health is improved, psychiatric conditions are improved, they're using less drugs, and housing is more likely to be successful. And then finally is our role in crisis prevention and post-crisis management. Crisis prevention because if they're being treated for psychosis with antipsychotics, if they're using less drugs, they're less likely to have a crisis. If they do have a crisis, when crisis comes, if they decide not to transport, we come on site and take over care. If they do take them to the hospital, we also go to the hospital and then follow them on the street to continue care to prevent the next crisis. And so right now we're at this really critical point in our history of street medicine where we're transitioning from this Robin Hood grassroots movement into mainstream healthcare. And we've gotten tremendous support from the administration, from a lot of you in the legislature, and from DHCS, to the point that we now have 57 programs across the state with another 20 in development in 34 different counties. So this is not just in the big cities. And so moving forward, as we're thinking about legislation, the goal would be to make it that anybody wanting to go to the street to deliver care is able to do so without bureaucratic barriers. Because there needs to be more of us to go to the people with love and solidarity.
Thank you very much.
Specifically to Brett, it's my understanding that California's current policy only allows for counties to provide services to those who are experiencing severe mental illness, and so can you give us a sense of how in Los Angeles and maybe Mr. Gelati can speak to this or Dr. Bonfatti as well, but specifically to Los Angeles, how the county is meeting those needs and what sort of gaps that we should work on to ensure network adequacy for folks with severe mental illness. And I guess street medicine teams such as yours, even if you have a psychiatrist, you're not allowed to provide direct services. And so could you walk us through that, the rationale behind it, whether we ought to look at changes in that direction? I'd love to hear about it. Yeah,
thank you. If there's one thing that I'd like to get done here, it would be that.
Places like Venice Family Clinic. I'm just thinking about all the different groups out there. Westside Family Health Center. Anyway, sorry.
Yeah, no. If as it relates to behavioral health, if there's one thing that would help, it would be changing that. And the reason is because, and I mentioned in the beginning, we run the California Street Medicine Collaborative with 130 organizations. So we have a sense of what's going on across the state in addition to LA. And so, but in LA specifically, where we have DMH, which is probably the most extensive DMH, I would guess, they have how they address people experiencing unsheltered homelessness is with their home teams. And they focus mostly on conserving folks. And so if you're not ready to be conserved, there's not a way to provide ongoing care. And they're only and each team only takes care of a very small amount of people. And so the vast majority are not being served at all, which is why our teams are providing the highest level of care that we can provide. And so we, in one of our statewide meetings, we were talking about how some of us, including USC, but others, employ psychiatrists and use them to help us with our most severe patients, make a diagnosis and a treatment plan, but then it's carried out by the rest of the primary care team. But folks aren't willing to hire more because they can't get reimbursed for it. So we really need to open up the door for anybody wanting to provide psychiatric services on the street to be able to do so.
So can you walk me through why the rules are the way they are? Your best understanding?
My best understanding, and I do street medicine, so I'm not an expert in this stuff, but my best understanding, it was that there's something in place, maybe it's that MHSA that makes it that put the counties in charge of this. And so the counties can bill for serious mental illness, but only the counties. And so for the rest of us that want to provide care, that we are providing care for the same diagnoses, but can't get reimbursed for it.
And can you, but you can't act as a contractor or agent or a servicer to the counties and get reimbursed through the counties?
So if
as happens in so many other contexts?
Yeah. So we've talked about that with different counties across the state, and it comes down to they're having trouble funding their own stuff. And, subcontracting with us would mean we would have to share the same pot of money.
Is that your understanding as well, Mr. Giletti?
Similarly, we have this alternative transport destination pilot program. San Francisco was the first department in the nation to try it. We have nurse practitioners and paramedics on our rigs, or doctors, medical doctors. We have 3 medical doctors on our department. We're fortunate in that way. And our whole program is funded by our department, even though the counties could reimburse. There's no
and you're a county
money
department.
to do that. I'm a county department.
Yeah.
But what we are doing, and I think opening everybody's eyes to, is when you look at Medicare and billing that we can get federally, if you had a medical issue in the field, we can get reimbursed for that call. Why are we not getting reimbursed through Medicare for a mental health call that we take a patient to an alternative transport destination or to a clinic where they can get the care that's different than the emergency room? We only get it if we go to the emergency room. So breaking down barriers on how we actually run the calls. The follow-up to that is how we can get funding and payment for that.
So we've been spending a ton of money from the state on homelessness, homeless services. There's not enough money. I mean, what some of the recent, $15 billion or $13 to $15 billion recent allocations from the state, isn't any of it going to these services? And what's stopping everyone from having adequate funding to address these challenges?
Yeah, so for street medicine in particular, a lot of our programs, so when I started this program in 2018, we were the 2nd in Los Angeles and the 6th in the state. Now there's at least 14 in Los Angeles and 57 in the state. And most of that growth has been because of a lot of the funding that was made available from DHCS. And it was short-term capacity building funding. A lot of it, like HIP, Housing and Homeless Incentive Program, is due to expire in about a year and a half. And so we're working as quickly as we can to get contracts in place with the managed care organization so that we don't hit this cliff and have to think about, not treating the people that all these programs have been treating. And so we've been trying to negotiate with the plans. The rates most of them are just offering standard rates. And there's a number of reasons if you're interested on why the equitable thing to do would be for street medicine to get reimbursed more. So that's everything within Medi-Cal. But then there's all this stuff that we do outside of Medi-Cal. So for example, the crisis response stuff, Medi-Cal is when you go to an individual who holds insurance in a specific plan that you have a contract with that you're willing to bill. But crisis call doesn't function like that.
Right. And so presumably it should be funded out of these collective and pretty robust state funding efforts through the counties and locals.
Yeah, I think so, because you can't ask a street medicine team who just like you can't ask a clinic who's relying on billing for managed care to respond to people that they're not, under contract with. And so that's what we would be doing in street medicine, which we actually do now, but it's not a sustainable model.
I mean, ideally, there'd be someone who goes and tries to make sure we're collecting whatever we can from the federal government to help at least offset some of the Medicaid-related costs or Medicare. Okay. Well, this seems like an area that needs some work on our side. And yeah, Mr. Gelati, I'd love to hear.
I'll just add something real quick, and I know we're short on time, but I think getting the services we're talking about here, which, as Senator Wiener said, is they're not in the box. If I were to go out and run a call and take that mentally ill patient with all the issues that could be treated by either street medicine or alternative transport destination, and I take them to the emergency room, I get full reimbursement. So where's the incentive to reach out to street medicine, have them on the rolls? Where's the incentive to not take them to the emergency room, but get them to the alternative transport destinations, mental health facilities, drug addiction centers? When in reality, if we're doing these things that we're talking about here today, we will not have the cost of the emergency services responding to them and taking them to the emergency room. Think about the offset that's there. And I think we're going to have to get outside the box, like the senator said, to say, we're going to approve some programs that aren't in the box, and we're going to get reimbursement for it. And then let's study what works and what doesn't and make sure that we keep funding what's working.
Yeah, and if I can just add one more important thing, they're at a distinct disadvantage, because right now, when they get called to a crisis response, there's two options. Number one, this is not a crisis, in which case they leave the person there, but something probably prompted the call. Or it is a crisis, in which case they transport them. The hospital keeps them for 1 day or 3 days, and then they go back out onto the street. And both result in the person back out onto the street without a reliable connection to care. And so that's really street medicine's role. Is they would refer to us and we would continue care.
Okay. We're going to have to move quickly because...
I'd love to work on this.
The Assembly goes into session at once. Yeah. Thank you. Senator Ashby.
Well, I can be very quick. Hello, President Gelati. It's nice to see you. I just wanted to say to my colleagues, really, that I have SB 1180, which deals with this issue and allows medical reimbursement for ambulances to drop off at alternate sites that are more appropriate for mental health and behavioral health services. So any of you who would like to sign on to that bill with me, co-author, I'd love to have you. Just holler at me, let my office know. There's no way to stop the revolving door nature of this if we just drop people off at the emergency room. My husband runs the local emergency room in Sacramento. All he can do is hold them for a little while and then release them, and then you can bring them back. If we really want to stop that and be effective, we need more than 988. We need more than street medicine. We need longer-term service provision and people who write out a plan for success. And there is no reason why firefighters would drop somebody off when they can't be reimbursed for that call. It's not a fair thing to ask them to do, although many of them are doing it. Many of them are. Sacramento, I know, is doing that. I'm sure LA is too. But it is not a sustainable program, and there's no reason for it to function that way. So thank you all very much for your work, and I'm honored to carry that bill and would love to have any of you sign on.
Thank you, Senator. Any final questions or comments? Yes, Senator Cortese.
Thank you, Mr. Chair. Just a question for Mr. Feldman, and a short answer is fine. If it's too complex, for today's hearing, we could talk afterwards and connect with my office. But we were doing Valley Medical Center, I think is the second largest public health and hospital system in the state, in my county, in my district. And while I was a county supervisor, back in 2014, we were doing in the largest encampments, what you're calling street medicine now, I think. And I participated in that as an observer and shadowing what was going on. The heartbreaking thing was that we would get folks like you're describing into a patient-physician relationship on a first-name basis, where they would be visited in their tents or in the large encampments like the so-called jungle. We'd get them on an Epic system. We'd have a file on them, and then they'd be swept. And all of a sudden, we've got no contact again. And that has been a recurring issue in the 10 years since 2014 when we first started doing that. How do you deal with that?
Yeah, it is a huge issue, and there was just a study published that it actually increases mortality whenever there's a sweep. A number of things. One, that's the part of the work of the community health workers is we call it a homeless advance directive, where we ask them, if you were to move, where are 2 places you'd be? And then also we try and figure out what their daily routine is. So just like you and I, they have a daily routine. So if their encampment gets moved, but I know that they're going to panhandle on a certain corner at noon, I'll just meet them there at noon. We still sometimes can't find folks, but it helps.
Got it. Thank you.
Thank you very much. Okay,